you can go online to nmact.org, go onto where it says links, and you will see where they say about us, and then you can go down to the sports medicine link, click on it, and you will find the pre-participation exam. That exam is very important because it gives you a list as a provider, gives you a list of all the things that you need to check for. And then there's also a small section just prior to the pre-participation exam. You can get online with the link through, I have that paper here. The New Mexico Activities Association has a concussion in sports fact sheet, and then once you click on it, you can go to other references sites, but it talks about Senate Bill 137, which is the new law that went into effect on July 1st. This law is important to note because it extended the time frame of removal of athletes from 7 days to 10 days. And that's a good thing, because when we're dealing with youth sports, we need to understand has stated that a minimum of 2 weeks is expected for youth to recover from a concussion. Now, there is no such thing as a mild, moderate, or severe. You either have a concussion or you don't have a concussion. But there are signs and symptoms that are listed on this fact sheet that tells you about all the things that you can see when it comes to concussions. So the first thing we're going to do is we're going to find out, as you're looking at the screen, developing a reproducible evaluation technique for a pre-participation exam. We'll talk about the concussion safety protocol. We'll identify predisposing conditions, and then we'll describe orthopedic components of PPE. I'm not going to go into anatomy, physiology, as I expect most of you should know this as well. So on the concussion safety protocol checklist, the brain injury and concussion history basically started. New Mexico is an amazing leader when it comes to concussions in the United States. Before, well, there was Oregon, and then there was Indiana, and then there was New Mexico. In 2002, we just wrote up a statement concerning concussions in the state of New Mexico. And in 2008, we wrote a state law. It was called Senate Bill 1. That was taken by just about every state in the union and modified for their own use. This was really important to us because New Mexico led the country when it came to understanding and doing the state law for concussion. You have to understand symptom evaluation, cognitive assessments, and balance evaluations. These are all based upon SAC-3. That's SAC-3. Those are from the CDC and also from the Brain Injury Council, which comes from Philadelphia, I believe. The team physician or the person who is doing the evaluation does the pre-participation clearance, and any consultation or testing for anything that comes up as abnormal or as a deterring effect needs to be taken and done on a separate level. The athletic trainers in the state of New Mexico can also do the pre-participation exam, but the physician must sign up on the rest of the cardiac and the lung and those kinds of things. But the athletic trainer does that, and that's why we're going over this. Diagnosis of concussion. Any student athlete with signs or symptoms of behavior consistent with concussion, they must be removed from practice and competition for that day. They may not return. They also have to be removed from school activity as well. So that's something else that you need to be aware of. It can be must be evaluated by an ATC or a team physician, and that will determine whether or not that is an individual who is ready to return. It must be removed from practice for that calendar day if the concussion has been confirmed. Then they must follow a stepwise program for return to play. One of the simple steps coming into this is understanding the basis of concussions. You have to understand the basis of the cranial nerve assessment and also understanding certain behaviors that occur with an athlete. So as that athlete comes walking in, you need to be noticing their balance, their coordination, their step performance, looking how they're walking, whether they're steady or unsteady, And then once you get them onto the table, then we can start doing the cranial exam. The cranial exam is very, very simple. What I almost always start with is something called the Spurs test or Sperling's test. How you feeling today?
Good, thanks.
Doing all right? All right. As I'm pushing down on the top of the head, what I'm looking for is any kind of movement that is going to go laterally or into flexion or extension. What this does is it tells me if there's any compression into the cervical notch. Then I'm going to put my hand onto the occipital notch and I'm going to press on it. I'm looking for the nystagmus in the eyes. It's very simple because you're pushing onto the vertebral artery, and that is one of the first arteries that becomes completed or occluded when it comes to concussions. All right, so I'm going to have you bring your head forward, all the way down, bring it all the way back as hard as you can. Come on, come on, come on, come on. Push down again, hard, hard, hard. Put your ear to your shoulder. Put your ear to your shoulder. All right, turn your chin to your shoulder. Now turn it against me. Hard, 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 hard. Go again. Hard, 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 hard. Now, anytime you have any raising of the cheeks, grimacing of the mouth, or nystagmus in the eyes, you will note that that may have been a prior concussion. And the reason for that is because of compression within the cervical notch. All right, so let's bring your arms all the way out forward. Hold. All right, put your hands together. Squeeze. Today. All right, squeeze. Pull apart. Hold, 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 hold. All right, so far we've done 1, 2, 3. We've done 4 rotation. We've done 5 for the shoulders. We've also done 4 nerve group. We've done 5, and we also done 6. Now bring your arms in, hold there. There's 7. Bring your fingers out. Squeeze. Pull in hard as you can. Notice the thumbs come up. That's C6 and C7. That's also C8. Now hold the thumbs together. Pull apart as hard as you can. There's T1. Now, any loss of sensation or any loss of strength in any one of those motions can tell you that you have a cranial nerve that needs to be reevaluated. Next. Can we add the concussion thing to that?
I think we've done this before.
Was that before?
Yeah.
Okay. All right. So, what is the basis of a concussion? We're going to go back a little bit. What is the basis of concussion testing? We want to look for cognitive, balance, and coordination. I'm going to give you 5 words. Lions, tigers, bears, zebras, giraffes. Repeat those for me, please.
Lions, tigers, bears, zebras, giraffes.
Okay. Remember those 5 words because I'm going to ask you repeatedly throughout this evaluation about those, all right? I also want you to say the numbers 6, 3, 4 in reverse.
4, 3, 6.
Let's try this again. 3, 6, 4 in reverse.
4, 6, 3.
Okay. Now, reproducible numbers, reproducible words can also be used as cognitive function. All right. We have a few other tests that I like to do. Want to stand up for me? Put your feet together as close as you can. Put your arms out to your side. Put your head back. Close your eyes. Simple wrong reverse test. Now what I'm going to have you do is raise your right leg. Raise it up. Hold it. Looking for balance. Put it down. Raise your left leg. Looking for balance. Put it down. Remember that some people are more strong on right versus the left based upon their activity levels. Don't freak out about that. What you're looking for is an obvious movement. Raise your hands above your head. As long as there's no loss of balance, we're good. Okay, now spread your feet apart as far as you can. All right, now they should be in really good balanced position here. Hands in fair position in front. Close your eyes, head back. Raise your hand above your head. So balance, good. Come back down and relax. All right, sit down for me. Something I like to use is called the stick test. Basically, it's just a simple ruler. And all you're doing is you're going to drop the ruler between your hands. You're going to put your hands out in front of you, about an inch apart. Now, what I want you to do is I want you to catch the ruler when I say go. All right? Ready, set, go. All right, look at the number on the ruler. It should be the number that you're seeing on top. All right, you're going to do that 3 times. Ready? A little closer together. A little closer. There you go. Ready? 1, 2, 3, go. Good. Ready? 1, 2, 3, go. Very good. Now, why do I do this test? It's a simple test because if you do not have a concussion and you grab a hold of that, you have cognitive function as well as peripheral function. So we know that the left and the right are talking together. We also know that the prefrontal lobe is also working very, very well. You get a concussion, this thing is going to hit the floor every single time. So if you have a concussion, whether you have just been pulled off the field or the next day you came in to see your athletic trainer or your physician and they do this drop test, guarantee as long as they have some form of symptom, including headache, nausea, tinnitus, or having some any form of hearing loss or any nausea or vomiting, they're going to have this test as a negative test. Guaranteed. All right. Other forms of tests. Tell me those 5 words again.
Lions, tigers, bears, zebras, giraffes.
Okay. In a concussion, after about 3 or 4 minutes and doing some other activities, they're going to forget at least 2. All right. It's okay. It's okay. Now, what were those numbers again?
4, 6, 3.
Very good. Very good. Now, why am I repeating these numbers? Because in cognitive function becomes delayed or has been retracted when you have concussion. This is why you don't want to take a child who is in mid-school or high school who has suffered a concussion and put them right back into the classroom, put them in a math class and say, okay, show me where X is. Right over the top of their head. They're going to lose function. And it may take anywhere between 1 to 2 weeks before that cognitive function becomes normal again, as long as they haven't had any other stimuli along with that. So one of the things on the checklist is a list of all the things you can and cannot do with the athlete after they've been removed from a concussion. One of those, very simply, no TV, no video, no iPod, no iPhones, nothing. No external stimuli that's ears or eyes. They should be at home resting and resting quietly. You get them into the classroom, there's a lot of noise, there's a lot of environment movement. Then they start to have a headache again. Some interesting things that have come up, and that is done through the Brain Injury Statement or Brain Injury Collaborative out of UCLA, have found that if the glucose levels of that patient have dropped, that their symptoms become worsened. But if you increase their glucose and are able to recover faster. One of the tests that we've done is we had a couple athletes with concussions. We gave them a big bottle of Gatorade. One bottle was a little bit heavier in dose. One was a normal Gatorade level, and the other one was just plain water. We gave it to 3 athletes. The one that had the heavier dose of glucose, the heavier dose of Gatorade, came back and said that his symptoms lasted or went away for almost 2 hours. And then he started feeling bad. Then he drank some more Gatorade, symptoms went away. However, that doesn't deter him from his cognitive function. His cognitive function was still really low. All right? So.
Does that mean a concussion gets you out of math for 2 weeks?
Concussion should get you out of school, period. Period, yeah. I would contact the school nurse almost immediately and let them know there is an app on, it's called Concussion, that you can go on to, and it costs like $3.99 or whatever. But it will go through all the tests, go through all the settings, and you just push the buttons and tells you where everything's at, including balance and then symptom evaluation. It lists all the symptoms, lists all the cognitive assessment, and lists all the balance assessment. And then you can then send that to the team physician or to their physician, and also send it to the school nurse through an email. And so they have automatic response to whether or not that athlete has been injured over the weekend. Something really simple to use, and I use it all the time. Okay.
Doc, real quick. So you've talked about some symptoms, a cognitive assessment in terms of the physical, in relation to the physical, the PPE, but can you talk a little bit about brain injuries and concussion history? So when you're doing the physical exam, what are some questions that you might ask an athlete in reference to this checklist or the fact sheet that you would engage in a conversation with your patient?
One of the first questions you should ask them, have you fallen down and gone boom in the last year?
No.
All right. Have you suffered an injury that you didn't tell anyone about?
No.
Why?
I didn't have any injuries.
Okay. All right. It's important to note that. Otherwise, well, I didn't want to tell the coach, so I didn't want to get pulled out of the game. All right. Okay. And they'll tell you because you're right there between them. All right. All right. Have you suffered a concussion in the last 5 years?
No.
Okay. Chances are, if they haven't suffered a concussion in the last 5 years, that their symptomologies would not be responding. Now, there are athletes that say, well, I got a headache last year in football, and I'm all right. What was 5 words again?
Lions, tigers, bears, zebras, giraffes.
2 of those are going to be gone. Or they're going to be reversed. Or they're going to be out of position. So they're going to be there, all right? So a cognitive function will tell me about that. Now, the other thing is, too, is if you have suffered a back injury or a hip injury in the last 5 years.
No.
Okay. Now, the reason for that is because back and hips have connection to the spinal cord. And the spinal cord can get involved when it comes to concussions. You can get overuse or repetitive traumas to the spinal cord when you talk about. Okay. All right. Any other questions about concussions? That was pretty quick. Yes.
Sir, we do have a question from the chat box. What is the name of the app you were mentioning earlier?
It's called the Concussion app.
The Concussion app.
Yeah. It's,
There's quite a few. You want to take a look
it
and tell
just says concussion.
Sure.
Keep going. On a roll. Sure about my phone.
Let me go grab it.
No. Any one of them, if it says SCAT2 on it or SCAT3, SCAT2 or SCAT3, those are perfect because they also have access to email.
Okay.
All right.
Okay.
SCAT2 or SCAT3. All right.
Thank you.
Any other questions?
Not so far.
All right, cool. All right. So now we go into upper extremity. Upper extremity is actually fairly easy to do. Obviously, it says bony anatomy and muscular structures. We don't need to really go over that. But you need to be aware of where you're touching so that you can do all the stress exams. I almost always start in the center and work my way out. I'm sure you've seen this before. It's just an easy way for me to remember going through the center, going to the outside. It's not a religious thing. It just helps me remember. All right. So we're starting on the sternoclavicular joint. We're doing a piano key test on the sternal. Going across the clavicle, remember where we're going to the middle of the clavicle, we get into the subclavian artery. Push on that and look at.
Just get a little to the side.
All right.
Sorry.
Pushing on the subclavian artery and then watching for the hand to turn either a bright red or a bright blue. Just simple cardiovascular function. Then we're doing a piano key test on the AC joint. Going to, this hurts, so don't push really hard or right on the coracoid process. But what I'm doing is I'm feeling that and then I'm seeing for any kind of jumping going on in the arms because the brachialis and the coracobrachialis run through there, and then also if you get like a burner or a stinger or they've had like rotator cuff dysfunction, you push on the coracoid and they get all jittery. All right, it's no big deal. As long as it goes away. If it stays and you let go and it still does that, you've got a problem. All right. Now doing a sulcus test, checking for the glenohumeral. We typically would want them to have their arm up. So when you pull down, you can see the sulcus and see it come back to neutral, which is good. All right. Okay. There are 3 other tests that you can use. The ones that I use almost always are the anterior and posterior drawer. Anterior posterior drawer, we're holding on to the humerus. Remember not to get into the axillary cavity, but just anterior to that. And then we want to grab a hold of the scapula as well as the clavicle, and we're going to draw forward and push back. Draw forward and push back. If you have an anterior posterior labrum, and you do the anterior and posterior drawer, you're going to get that drop, and it's going to move very significantly. Hawkins-Kennedy test, arm is externally rotated, abducted, placing your hand onto the forearm. Basically what it does is you can see here, do it again, there's a sulcus. And that sulcus is important because you want to look to see if that glenohumeral joint slides anteriorly. Almost all labral injuries to the shoulder occur anteriorly. The reason for this is because we like going forward and we don't like stopping. Unfortunately, to get a tear of the anterior labrum, you have to stop. So they're either going to have their arm out in front of them or in the foosh, or they're going to put their arm back and it's going into the foosh and it's going to stop in the directed motion. So the Hawkins-Kennedy test will tell me if you have a rotator cuff as well as an anterior labrum. The last one is called the Speeds test. You're going to bring your arm up as fast as you can. I'm going to hold there, but I'm going to place my finger right on onto the coracoid process, and you're going to feel it click if it has any kind of bicipital groove or bicipital tendonitis. Bring your arm up quick, go. It should feel something get heavy and then go away when you release. If it goes like that, you have bicipital tendonitis, and that's very common in females between the ages of 11 and 15 and males between 13 and 17. All right, the reason for this is because they're always doing this. Think about volleyball, basketball, football, baseball, softball pitchers. Baseball pitchers, if they're not throwing curves all the damn time, that we'll worry about the elbow later. Right now, we're talking about the shoulder going forward and then releasing. Every time you release your shoulder, moving that shoulder joint apart because it's internally rotated, it extends, it comes back in. And that's what's holding it together as a glenohumeral joint. Okay. Next, the elbow. The elbow is extremely complicated for a lot of reasons. One, it is a pivot joint, it is a rotational joint, and it is a humidity joint. Now, the reason for all that happy stuff, simply because the ulna and the humerus act as your pivot. However, you also rotate in pronation and in supination, but you also can introvert and extrovert the shoulder, the elbow. So it's somewhat of a complicated system. Don't worry too much about it. All you want to look for is bring both elbows out. Okay. Any kind of recurvatum, anything more than 15 degrees, you don't need to break out a goniometer. If the elbows touch when their arms are out in front of them, chances are they have recurvatum. If they have recurvatum, then the chances are they're going to have some type of ulnar dysfunction or ulnar collateral dysfunction. So you need to be aware of that, especially when you're playing sport. Okay. If it's not, 10 degrees is fine. 5 degrees is fine. If you have a varum, which the elbow comes out and comes in, they should be precluded from sports, because if they have varum, they also have something wrong with the wrist, as well as something wrong with the shoulder, and they should be evaluated by an orthopedic surgeon. And there's going to be some form of dysfunction within that joint. So I would be very cautious about that. If it's just plain straight and there's no recurvatum at all, it's normal. But you'll see a varum. It'll come out and come back in. It's highly unlikely that they'll be participating in sports, because they also have other things as well. They probably also have more events in them. Just FYI. Okay. All right. So on the elbow, very simply, making sure that you hold one side, the lateral side. You want to stabilize the humerus. I'm placing my fingers right underneath the ulnar head, and then I'm going to apply a valgus stress, and I'm going to open up that joint. I'm going to reverse on the medial aspect and do a varus stress. All right, so valgus, varus. Then once again, we can do an anterior drawer. We're just placing our thumb right into the capitular space, and we're going to draw forward. We're going to feel for it clunking. If it clunks and then we release it, it goes back, that's good. If it goes out, you mean you just dislocated the elbow. You might want to put that back. And the easiest way to do that is putting your fingers around the surgery fingers and then doing that. And it goes right back. Just that way. All right. The other test that I would do is the glide test. You could do the glide test also here. It tends to be a little bit harder to do. That's why I like to do it in this position here. So I'm holding above the wrist, by the way. I'm holding above the wrist joint. So I'm gliding out. So I'm using the radius and the ulna as the fulcrum. And I'm feeling for the electron arm process with my finger in the back, in case you didn't see that. I'm putting my finger back here. Okay. All right. The Bacchus severus, posterior glide. Pronation and supination are important for the elbow, but it's more for the wrist. But it's easy to test for. Place your hands here. Okay. I'm going to grab a hold of the thumbs underneath. Put my fingers across the palm. Now turn your hands in. Now pull them back out. And what I'm looking for is when those elbows go in and when they come back out when I rotate them. And that's really easy to see.
Can you do that one more time and
Okay.
step to the side for me?
All right, so I'm going to turn your hands in. Now turn your hands out. See how the elbows go out and the elbows come back in? All right, that's an easy thing. If they don't, then there's something wrong with the ulnar collateral ligament or with the capitulum. Hand and wrist. The most commonly dislocated joint of the wrist is the scaphoid lunate joint. Most people have this problem when they fall down the room. It's because they have thoosh, fall on an outstretched arm. All right, the reason for that is because the lunate and the scaphoid is right off the thumb. So find your thenar space, go all the way down, and you'll feel a bump. All right, when you put your finger on it, it should glide up and down. Right next to it is the lunate. Oh, that was good. I just sorry. All right, the lunate is right in the center of the carpal groove. All right, so when you push down on it, as long as the fingers don't turn blue, we're good. If you push on that and the fingers turn blue and you let go and they don't come back, have them bring their hand into extension. All right. So relax. So now we're going to do the glide test. So we're going to grab a hold of the ulna. We're going to find our thumb and put it right on top of the pisiform. All right. And then we're going to glide forward and glide back. So we have an anterior glide, posterior glide. Do the same thing to the scaphoid. So we grab a hold of the thumb right on top of the scaphoid. We're grabbing a hold of the radius, and we're going to glide forward and glide back. Anterior and posterior glide. Okay, let's use this one. So we're going to glide anterior and posterior. Ooh, there it goes.
Mm-hmm.
Okay. Now, when you have poppy wrists all the time, please don't panic. Don't be trying to pop your wrist, okay? The lunate is in the shape of a moon, and the scaphoid is in the shape of a peanut, and it fits into that groove. And what happens is it tends to pop over, and that's what gives you that popping sensation. Don't get too worried about that as long as they have abs, flexion, and extension of the wrist, okay? All right. Next, we want to look for, I always check for Bennett's fracture, even though it's not necessarily happens that often, but I always check for that. I grab a hold of the MCP of the thumb and I glide it forward, and I want to feel for the groove between the scaphoid, the triquetrium, and the first shaft, and then I'm just going to put that groove in there and just slide it back and forth. If you have pain, it radiates down into the thumb. Chances are it's probably going to be some form of a thenar eminence or a Bennett's fracture. Tapping on the thumb will also do that as well. All right, Phelan's test. Phelan's test is here. Elbows all the way out. Push in as hard as you possibly can. All right, looking for color changes, relax. Bring your hands back up. Notice the color changes go back. All right, push. Turns pink, relax. Goes back to normal. Now, to curvates, flip your hands over. Now, this one will test for scaphoid. All right, push in and relax. Now, when they push in, if they have a scaphoid fracture or they have a lunate dislocation, the pain is going to radiate to the electron arm process. Push in Relax. Okay. All right, pinch grip test. Finger and thumb together. Hold. They should be able to grip it. That tells me that the thenar surface and the thenar muscles are strong enough to do that. And I already talked about anterior posterior drawer. Handiest tool on the planet is a tuning fork. All right. Yes, there's a hammer on the end. No, you don't need to test for reflex. Why? Because they walked in, they have reflex. Don't make this complicated. All right. The reason why I use the tuning fork is because the rubber tip, once you make contact with it, it vibrates. If you put your fingers out, put it on the end of the finger, it's asking where the vibration goes. Just to the tip?
Just to the tip.
All right, good. It's a good sign. You don't want that going anywhere. Putting it on the radius. Where's the vibration go? Nowhere. All right, put it on the electron process. Anything? No. All right, so we ruled out fracture. Because the vibration will go to the side of the fracture and stay there. And it actually becomes very uncomfortable. All right, so it's one of the easiest tools you can use, and you don't have to spend $85 on an APD on an X-ray. FYI. Okay. The pelvis, here we go. All right. Male versus female pelvis. You should know the difference, please. One of the things you need to be aware of, however, is that when they are laying down flat and their legs are up into Ober's position, they should have a flattened pelvis. So what I'm looking for is I'm going to place my hand directly underneath the lower back. Relax, relax. I can't be able to put my hand there. Now, put your legs down flat. Now I'm able to slide my hand directly underneath. Now we know we have at least a 5 or 7 degree curvature, which you need. I'm going to feel for the iliac crest. I'm going to go down to the ASIS. I'm going to push on the ASIS on both sides, and I'm looking for any kind of a translation. The other thing I want to look for is I want to look for any kind of lifting or movement of the thighs. So if I'm pushing down on the ASIS, they shouldn't push against my arm. All right? Now I'm going to go to the PSIS, and I'm going to lift just gently. Any pain or dysfunction there? Okay. Any pain when I push down?
Yeah.
Where?
My lower back.
Lower back? Okay. How long have you been running?
About 3 years.
You using the same shoes for the last 3 years?
No.
We talked about that, didn't we?
Yes.
Yes, we did. Okay. All right. All right. Go straight to the acetabulum. And interesting thing to note is that if you're between the height of 5 foot and 6 foot, and everybody's standing together, your acetabulum should be the same height all the way across. So while you're watching that wonderful NFL football game the other night, hopefully you won't watch it because they're terrible, but you'll notice that people between the height of 5 foot and 6 foot, when they all line up on the line, like when I watch my football team do it, everybody goes down and they're all the same height. Everybody. When they all stand up, yes, they may be a little taller, a little shorter, but they're all the same height at their pelvis. So watch their hips. Don't watch the ball. The ball never gets hurt. You can replace the ball. All right? Watch the hips, because when the hips move, you can tell which way the game is going. Just like in volleyball, you can watch everybody move based upon their hips. Now, it sounds weird to watch hips, but that's what we do. Okay. So now, bring this knee to your chest. Bring it down. Any pain?
No.
Knee up to your chest. Down. Okay. Straight leg up. All the way up. There you go. All the way down. All the way up. There you go. We're looking for changes of hamstring strength. The majority of lower back and lower injuries, lower leg injuries, occur because of tight hamstrings. And there isn't a teenager on the planet, with the exception of maybe a few gymnasts and maybe a few long distance runners, that don't have tight hamstrings. So when they put the legs down flat, now raise your leg all the way up, they have to get to at least 90. All right? That's minimal. Most of them get to about 45. So all you have to do is place your hand onto the heel and then raise their leg up, and that leg should stay stable. This should not move. This will. And yes, it starts to shake. Okay. Iliac compression we've done. Femoral glide we have not done. Femoral glide, slide towards me a little bit more. Keep going. I'm not going to let you fall off. Grab a hold of the table. Thank you. All right. Femoral glide. All I'm going to do is I'm going to bring the leg up to 90 degrees. I'm going to let it drop out. Abduct, 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 and then push down on it. And I'm going to feel for the acetabulum to glide through, find the femoral head that glides through the acetabulum. All I'm doing is look and see if we might have a labral dysfunction of the humerus. It should be a popping sensation, a gliding, like a grinding, like crepitus sensation. It'll go, and it's very obvious, especially, you don't even have to place your hand on the hip and feel it. You can feel it into the knee. It's a very distinctive feeling. And a lot of younger females are going to have this. Just FYI. If they have pain when they're running or hopping, and they're having a pain in femoral glide, send them to an orthopedic surgeon to make sure that they're not having a labral. Okay. Favors and faders. Bring cross the leg over. All right. There's internal and external rotation, and that's Faber's test. We can also do crossover. Bring your leg down, 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 down. Pull your leg up, 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 up. Okay, good. So there's Patrick's and Faber's test. Probably everybody's favorite joint. It's also the worst joint to evaluate. Slide back just a little bit more. Okay. All right. Knee is not that complicated. It does end. It doesn't. It internally and externally rotates. It also abducts and adducts, or it also has Ellery and Ellery. Don't let that freak you out. For test. Valgus, holding onto the joint inside your arm. So if I was going to do this, I'm going to hold it up against my body. Place my hand on the lateral valgus force. Open it 0. Bend it at 20 to 30 degrees. Do this looking for a movement. With this hand, we're stabilizing with this hand. This hand and move. We have valgus and varus. Now to do the opposite side, once again, stabilize body. I can do 0, and I can do 20. If it's probably some ligament dysfunction. The next one is apprehension. Finding the kneecap, finding the patella, the supple, and then run your fingers laterally and medially. That should not cause any problems. Shouldn't. If you go all the way over medially, you may feel the underside of the pole of the patella. Don't worry about that. You can do the same thing laterally. Most patellas glide or dislocate medially. When that happens, the knee is externally rotated. You just straighten out the leg, the patella pops back over. All right, the last one's called Clark's test. Making a C, placing it on the superior pole. Remember, you're going to tighten up. You're going to feel a sensation. Tighten up. All right. If it glides, clicks, grinds, crunches, pops, anything like that, that's a positive Clark's test. All you practitioners out there, please, if they are between the ages of 12 and 17 and they are doing activity, don't do the Clark's test that their knee pops when they're in activity, because it will cause a clicking. And you go, oh, it's a positive Clark's test. We need to go to a big surgeon. No, that is chondromalacia, and that is very, very common. All right, anterior posterior drawer. Stabilizing the foot, behind the knee, draw forward, push back. Anterior posterior drawer. Lockman's is a little bit more difficult. I stabilize underneath the arm, bend the knee at 20 degrees, and I raise the knee up at 20 degrees. Positive test, it goes out. Let it go back in, call the surgeon. Okay? McMurray's test. 90 degrees, fingers on the joint line. You're rotating medially, rotating laterally. It's okay to get a little click, but if you have a click and pain, McMurray's is positive. Okay? All right, sag test, pivot shift, and screw home. Sag test, very simply, is this. Fingers again on the joint line, internally rotate the knee, let it drop. You want to see them try to stop that joint from moving. If it doesn't stop, the ACL and the PCL are pretty much gone. All right? Now, screw home mechanism test. Knees are bent. 90 degrees. We're going to take the feet, externally rotate them. And what we're looking for is the patellar ligament attaching to the patella, attaching to the tibial tuberosity, and we're looking for anything more than 10 degrees of movement. And right now she gets 0. So that's a good sign. All right? And that's the screw home mechanism test. All right, lower leg and foot. All right. Sit up for me. Can we pan down, Kevin? All right. So on the ankle and lower leg, you run your fingers along the tibial plateau. As long as there's no pain, we're okay. Typically. I've heard people say, oh, I got shin splints. Worst term ever. All right. Lower leg pain, yes. Shin splints, no. Horses get shin splints and then they shoot the horse. All right. Humans don't have shin splints. You have lower leg dysfunction. And the reason for that is because you could have compression, you can have a torn muscle, you can have an imbalance of muscle tissue. There's all sorts of things. Don't just say I got shin splints. It irritates athletic trainers to death. Okay. Anterior posterior drawer. You want to grab a hold of the heel, grab a hold of the forefoot, and then put your other hand on top of the lower leg, glide forward, and push back. That's the anterior posterior drawer. To make it fun, all you do is you put a depression system on it or decompression, and that's called Kleiger's test. So I'm going to pull down on the leg and do the same test. And then that pain will be up above the joint instead of on the joint. If it's on the joint, it's probably ATF on lateral side. If it is above the joint, it's probably a syndesmosis sprain, and they probably walk in on their heels and not on their toes. Anybody's ever sprained their ankle will tell you when they stand up, when they start to walk, that they can't put the pressure on the top of their foot. They have a syndesmosis injury, they can't put pressure on their heel. So they're kind of walking in toppy, all right? Distraction test, tailored distraction, all you're doing is you're taking the joint and you're dropping it down, and then you just kind of tilt it.
Can you pan? I don't think we got that on the camera.
Okay.
It's right there.
So on a tailored test, you're grabbing hold of the lower leg again, and then you're just pulling down and just tilting from side to side. So even if it was up here, and tilt down just a little bit. There we go. So I'm going to pull down, and I'm going to internally supple or functional flat foot. Now we get to kick off our shoes. Now,
Socks too, or?
please. Oh, you're wearing the same color socks today. That's awesome. Very uncommon to see that happening in schools anymore. All right, stand down on the floor. Okay, so what I'm looking for is I'm looking for an arch. I should be able to put my finger underneath the medial line. All right, so that's medial longitudinal arch. All right, so if they're standing up and they have an arch, chances are they don't have an arch support. Now sit back down. That is functional. If their foot is flattened, that means that they are pronated. All right? If they are supple, that means that when I look at their feet, I want to see a good curve on the foot. If their foot is flat when they're sitting, then they have a functional flat foot. They have a supple flat foot when they stand up and their foot flattens down. That's a supple flat foot. Supple flat feet need exercise. All right, they need to move the joint so that they can tighten up the plantar fascia. All right, we already did the standing single leg in opposition. Now we're going to do a squat to stand. Okay. Is you're going to squat down. And then come back up. Look at their feet. Make sure that their heels don't come off the ground. Do it again. See the heel stay stage? Now come back up. All right, the last time you were able to do that normally was when you were about 1 to about 3. Okay, just so you know. All right, put your feet together, reach down, touch your toes. We're looking for a balance between the spine, looking for a straight line. Yes, we're going to get about a 5 to 10 degree curve on scoliosis, which is normal in most adolescents. Now stand up, and we're watching that line straighten back up. Let's do it again. If you start to just find the PSIS, put your thumbs on the PSIS, now stand back up. And that curve will go away. If it doesn't go away, it probably should be evaluated. Okay? All right. So we did spinal alignment, we did scoliosis, we've already done the Romberg test because that was one of the first tests we did when we did concussions. Leg length and arm length, really basically all we're doing is making sure that the thumbs go past the acetabulum. All right, if the thumbs go mid-thigh, that's long length. All right, the other thing that we're looking for is Q angle. All right, so on this, all we're doing, I'm going to turn you this way. All right, all I'm looking for is from the acetabulum to the center of the knee, to the center of the heel. And I can take a tape measure or a string and just run that Q angle up. Female should have at least 15, male should have at least 10. That's all we're looking for. Now, if we have a greater Q angle, more than 15 degrees in a female, they're going to be complaining of snapping hip syndrome, and they're going to have a C form. So I find a C, and they're going to be right over the top of the acetabulum. That could include snapping hip syndrome, could be piriformis syndrome, could be anterior and posterior labral dysfunction. It could be a lot of things. Okay? All right. If it's normal and they're not having any pain when they're moving, then everything's fine. Okay? Have a seat. That's it. Anybody have any questions? I know that was quick. I'm sorry that was quick. But when it says 2-minute ortho, it really means a 2-minute ortho. So, yes.
I actually have a question to go back to concussion. Being a clinical psychologist, what is the research being done or advocacy or education regarding the correlation between concussion and suicide?
Okay. That's actually a really good one because CDC just came out with a statement. The National Athletic Trainers Association, the CDC, and the American Brain Council also have a position statement stating that cognitive dysfunctions does lead to suicidal behavior. And there's like a 30% gradient. I'm not really sure how they came up with that 30% gradient, but if you figure 30% out of 30 out of 100, that's a huge number, huge number. That's why they say do not return them back to play until the cognitive function has returned. And I am adamant about the fact that you don't let an athlete or an individual return to any activity while they are symptomatic. Oh, I'm fine, coach. I'm fine, coach. Tell me, where's your head hurt today? I think, oh, right there. Oh, you told me you didn't have a head. Okay. All right. Ow, that hurt. Okay. Ow, stop. All right. Photophobic? Autophobic? They have a headache? Are they symptomatic? Yes. 3 things, right? 15 seconds. Guess what? You're resting today, and I hope you have a great rest. And I'll see you tomorrow. Every 24 hours, check them. Cognitive function. They go to class. On something local. And then they start to write, and then, headache. Because they have to really concentrate on what they want to write down. Make them take a test 2 days after they have a concussion? No. Yes, is there a lead into that? Concussions lasting longer than 14 to 21 days? 14 to 21 days is a very long time. They become depressed. They become lethargic. They also have social reactions. They start to hide themselves. Hey, those are signs and symptoms that they need to be seen and they need to be talked to. And just every single day you talk to them, that's fine, but you need to have contact with them. All right. I'm not a psychiatrist. I'm an athletic trainer, but I know my athletes. We got a problem. You get that kid who has never talked at all, and all of a sudden he becomes the clown in the athletic training room. There's a red, all right? And you can then look at those. Actually, you also follow the listing. And now it also talks about who else to talk to, like the coaches and the other students. And your other athletes are huge when it comes to having those problems because they're going to see them in the hallways. Go talk to the teachers, talk to the school nurse, talk to them, ask them about how that individual is doing. And don't be afraid. Ask them. Okay? Any other questions?
Yeah, and I wasn't sure, Kevin, I can't really see the board.
1 minute.
Okay. Is there any
No other
questions?
questions
Okay.
that I've seen? No.
Okay. Anyone else in the room? Any questions?
I believe that we included the handouts for those.
Yeah, they're on download.
So you can actually load them directly from the Envision New Mexico calendar page. When you click on this event, there should be a handout that's there, including the checklists and everything, but they can be accessed there. And I know eventually we're going to be getting all of the associated handouts on the AHI web page as well. So you can certainly go there to download.
And you can contact me through the New Mexico Athletic Trainers Association. It's nmata.org. I'm actually listed as the parliamentarian. I'm not the president anymore. But as listed as a parliamentarian, if you have any questions, you can get a hold of me on my email. I'd be happy to go over that information with you if you need some more.
And we have a question that has come through. If those of you need to leave, you're welcome to sign off, but there's a link for the satisfaction survey that Kevin has put up, but I'd like to address the question that has come through. Student had 3 concussions last season. If not symptomatic this year, should they be cleared to play for current season?
According to the CDC, the NATA, and the NCAA, along with the American Pediatric Society, 3 concussions in a season is a disclaimer, is a deterrent for return to play for their career. They should be null and void. They're done. If they have 2 concussions in a season, they can't play the rest of that season and the following season. They may return after evaluation within 1 year. Those are standards. If they've had 3 concussions this year and they're not symptomatic, they need to see a neuro.
Do they need neuro to play, or can their provider bench them?
They'll need to see a neuro, and they're going to be benched. I would probably tell you they're going to be benched. If that was my son, and my son had 3 concussions, I'd be really, really worried. I really would be. There's a lawsuit for Yaffle in Texas. There are 3 young kids between the ages of 5 and 7 that had passed away during playing Yaffle, and parents are suing Yaffle. All 3 students at the age of 7 had CTE. That's huge. That's what we're finding in these professional football players. It's huge. No, I wouldn't let them play.
Thank you for that question. It was a really good question. So as you see, Tim is an amazing resource. So if there's any questions, please feel free to contact outside of today's presentation. And as Caitlin mentioned, we'll have the handouts on, and feel free to the website and the Concussion app. So thanks everyone for joining us today, and we will be back next Wednesday, same time, same place.
Thank you again.
Thank you.
For next week, I don't believe the link is quite up yet on the calendar, so just we could wait a couple of days. We'll be getting that up. Oh, it's up. Yeah, it should be up very soon. So we'll have a motivational interviewing talk next week from Jeannie. So we'll see you then.
Thanks everyone.